Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. Today we're continuing the lectures on obstetrics and gynecology. Newsflash, babies come out of moms. I bet even you came out of a mom. It's a miraculous experience, and as a parent, you never forget the feeling when you see your son or daughter for the first time. Now, someone somewhere said that most babies can be born in a cornfield and never need a thing to be healthy and happy. Well, if you're planning on practicing only in a cornfield, then you can stop the video right now and get to it. For the rest of you, there's a bit more to it that you might want to know, especially when it comes to actually delivering a baby. Now, today we are referring only to normal labor and delivery. None of the really scary stuff today. We're sticking to the normal things, but even normal labor and delivery can be a bit fear-inducing on occasion as well. So let's get started. So at this point in pregnancy, mothers have endured at least 38 weeks of pregnancy, and most are very tired of being pregnant at this point. Now, they are finally at the point where they get to meet their new child. Mothers, fathers at this point will be at their most excited, but also at their most anxious state of mind. So therefore, it's up to us not only to keep the mom healthy, to bring the new baby into the world healthy, but to explain everything to the parents, to make this event as happy as possible, and if you let it, it can be a very rewarding experience for you as well. So first, let's start talking about maternal changes before labor. So women will undergo some important changes as they come closer to actual labor. First, women as they approach term will experience the all-important uterine contraction. Now, very weak, spontaneous uterine contractions occur throughout the pregnancy. It's not just at labor that these occur. Now, most of them are imperceptible to the mother, though you will find that your more experienced mothers will be aware of these even more towards the beginning of their pregnancy than as much as they do at the end as well. Now, your first-time moms may not really know what's going on. It sort of feels like gas or something, but sometimes you really can figure out that these are contractions early on in pregnancy. As the mother gets closer to term, you see an increase in frequency and strength in these contractions. These are termed Braxton-Hicks contractions. They're also referred to as false labor. Now, it's an important distinction to know that it's only false labor or Braxton-Hicks contractions if there's no dilation of the cervix. If there's dilation of the cervix, then you've got real labor going on or something else that we really need to figure out. Other characteristics of these Braxton-Hicks contractions is that they're usually irregular in duration and timing. So you might get a contraction and then 10 minutes later get another contraction, and then 14 minutes later you get another contraction, and then 7 minutes later another one. And they're also less severe than true labor contractions as well. But especially for our less experienced mothers, these contractions may seem like real labor because they still hurt. Often these types of contractions will resolve with ambulation, hydration, and analgesia. So if you have a patient who calls you, especially if they're not term yet, and they say, well, I'm having some contractions, they're sort of irregular, the first thing I tell them, well, you need to drink a big glass of water. If you've been out in the heat or if you've been messing around too much, sit down and rest. If you've been kind of laid up all day, not doing anything, get up and kind of walk around. Nothing too strenuous though. And most of the time, that will resolve your contractions right there. Another change that occurs before the initiation of true labor is the descent of the baby's head into the pelvis. This is referred to as lightening. The patient will notice a change in the shape of her abdomen and will have a sensation that the baby is lighter. It's kind of moved down, and then that's why we call it lightening. The lower abdomen may become prominent, and because the baby's head is lower and pressing on the bladder, the patient may have to go urinate more often. It's a very common complaint. But on the plus side, because the baby is lower, it's not affecting the diaphragm as much. So you'll notice moms will have a lot of trouble with dyspnea, feeling like they can't catch the breath because they got a baby pressing up against their diaphragm. After lightening, well, I can breathe a little bit better. So that's a good sign that at least we're moving towards actual labor. The third major change that can occur before labor is what we call bloody show. So this is a passage of blood-tinged mucus, and this indicates the beginning of cervical effacement or thinning. All right, so let's keep moving on. Let's talk about evaluation of labor. So let's go through what you're going to do and what to expect when a patient comes into labor and delivery. So you're on call, you're sitting there, you've got a bunch of pregnant moms around you. Let's figure out what we're supposed to do when they first walk through the door. Hopefully, The patient has either her medical records with her. Oftentimes you'll have people with little cards that have a lot of information on it. Or records are already at the hospital, or they're easily accessible with electronic medical records. This is going to become an easier process of obtaining all the important information. The first thing I look for is dating. How far along is this patient? You really need to know this, and since this is normal pregnancy that we're talking about, normal labor and delivery, we're going to assume that this is a term pregnancy. But you definitely want to look for good dating information. Were they seen early in their pregnancy? Do they have a good EDC? Do we have an ultrasound? Does that ultrasound confirm our dating? Or are we only going from an ultrasound, and how far along in the pregnancy did we take that ultrasound? Now, again, since we're talking about normal labor and delivery, we'll assume that this is term. Other things you want to look for on this card of information: hemoglobin and hematocrit. Was there any signs of anemia during the pregnancy? Blood type, very important. Is this an Rh negative mom that might require RhoGAM? Screening for HIV, hepatitis B, syphilis, and very importantly, group B strep. You want to look for the glucose loading or tolerance test to make sure there's no gestational or diabetes mellitus. And again, for this lecture, we're assuming all these are normal. Another clue looking at the info card or the past medical records is how many visits, how many prenatal visits did this patient go to throughout this pregnancy. Now, occasionally you'll be sitting there, especially in residency, and you'll have a patient coming from out of county or didn't go to your clinic and they've been seen once or twice. Well, you should ask the patient about that. Maybe they do have some other medical records somewhere else that they just don't have with them. But that can be an indication of a higher risk pregnancy. If someone doesn't get prenatal care, they're automatically at a little bit higher risk. All right, so next we've gathered our information. Now we want to do a physical exam. Now, first, obviously, look at the vital signs. You want to make sure there's no signs of hypertension or hypotension. Make sure there's no signs of tachycardia, any signs of shock, anything that makes the patient look unstable. Now, the most interesting aspect of the physical exam in relation to a pregnant patient is usually the abdominal exam and the pelvic exam. Still doesn't mean you don't have to do the rest of the physical exam, but that's what we're going to concentrate on today because it's the most pertinent to what we're talking about. Abdominal exam. So if the patient is having contractions, then you can actually feel on the abdomen the general strength of those contractions. You know, it's really interesting. It can get hard as a rock. So you can get an idea of just how strong these things are. Obviously, this is very subjective, but it can be helpful. Next, we're going to check fetal heart tones. So a lot of times you'll have your little wand, your little Doppler fetal heart tone monitor. You can check it right there. Oftentimes, if you're going to be in a hospital or in labor and delivery, they're going to have the straps. They're going to have that continuous electronic fetal monitoring. And we're going to talk a lot about that later in the lectures. Next, you want to attempt to figure out the fetal lie. Now, you can use Leopold maneuvers, which involves palpating in 4 different locations in order to figure out which direction is this baby going, where are they facing, and all that type of stuff. So first, you're going to reach at the top of the uterus, so at the fundus, and you're going to feel around there, see what you feel is a part up there, if you can sort of feel legs squirming around, or if you can feel a buttock. And then you're going to move on to the sides of the baby, per se. So on either side of the uterus, and then finally you're going to palpate at the bottom, kind of where the pubic symphysis is, right above it. You're going to kind of push your fingers far down. Hopefully you can kind of grab a head and get an idea of what's going on there. Sometimes Leopold maneuvers can be difficult, especially in our obese patients, but remember, you're starting at the top, then you're feeling on both sides of the baby, and then you're feeling down at the bottom, kind of where the head should be. Also very important is discovering the fetal presentation. So don't get confused with lie and presentation. Presentation means what's head down. So is it a breech presentation? Are the feet or the buttocks presenting first, or is it going to be the head, which we like to have as the presenting part? We refer to this as either vertex, or probably more accurate is cephalic. So you want to have head down. And again, this is not always cut and dry. You know, even experienced physicians can get the presentation wrong. And if there's any doubt when considering which direction that baby's facing, you might want to use an ultrasound. There's very affordable bedside ultrasounds that most hospitals will have at this time. So if you're sitting there like, yeah, you know, I kind of feel like I'm not sure what's going on, just, you know, stick that ultrasound right there and then look for that head. The next step is the pelvic exam. So one very important aspect of this exam is determining whether or not the membranes have been ruptured. So we've done our abdominal exam. Now, first thing we're worried about in the pelvis is, do we have liquid coming out of it? So in 10% of pregnancies, the membranes will rupture prior to the onset of labor. This is called premature rupture of membranes, or PROM or PROM. Don't get this confused with PPROM.